أنا ممكن نجاوب على الأسئلة اللي تحبون يعني نجاوب عليها. الرقم مالتي موجود بالجروب، أي وقت تحبون تتصلون بي، تدزون رسائل تسألون عن أي شيء ببالكم بخصوص هذا الموضوع أو بخصوص أي شيء آخر. ف يعني أنا حاضر. أنا حاخذكم تقريبا بعد أسبوعين. ف أنا أحب الميت، جوجل ميت، بس قال لي صالح إنه مو كلكم فاميليار ويا الجوجل ميت. بس أنا حاخذكم أسبوعين القادمة. أيضا حاخذكم الوايت بي سي ديس اوردرز والار بي سي ديس اوردرز. فممكن يعني تصير عندكم بالشات إذا صار عندكم مجال تعطوني مقترحات على مود يعني أقدم لكم في شيء أفضل من اللي صار اليوم. احنا بالنهايه تقريبا محاضره البروسيس مشينا عليها مشيه جيده. مرات الفيديو اذا حتشوفون الفيديو شويه يختلف عن البي دي اف، لانه الفيديو بي اكثر شيء صور، والبي دي اف بي اكثر تكست. فانتوا يعني اقروا بالطريقه اللي تناسبكم. كلش مهم وصحيح يعني وضع صعب، لكن انتوا هسه قاعد تتعلمون طريقه. احنا بالتعليم الطبي نقول هذه طريقة ممتازة، لأنه هي student oriented teaching. The best way to learn is to have your own effort. So you are. فاحنا معتمدين عليكم انه تطلعون على المحاضرات، تباعون فيديو. اذا عندكم اسئلة يعني يستنتج اي وقت تطلبون على الجروب تحبون بشكل خاص. انا رقمي موجود بالجروب، ممكن تتصلون حسب ما يناسبكم، حسب الوقت اللي يناسبكم. اعتقد انا اكمل. احنا وصلنا للفينس ثرومبوسيس. الفينس ثرومبوسيس مثل ما تعرفون من الاناتومي، عندنا superficial veins، وعندنا وعندنا عندنا superficial veins، وعندنا deep veins.
ديب.
فالsuperficial veins اللي هي ها تمام طلعت الصورة. يعني هاي دائما القاعده مالتنا انه السوبرفيشن فينز هذه اللي احنا نسحب بنعدها دائما، اللي موجوده نشوفها بالايد وبالاقدام مالتنا وتكون واضحه. فهذه عاده قليل ما يصير بها ثرومبوسس الا يصير إذا صار عندنا في شيء نسميه فاريكوز. الفاريكوز معناها بالعربيه يسموها الدوالي، اللي هي معناها عندنا abnormal dilatation of superficial veins. This abnormal dilatation lead to abnormal blood flow and lead to thrombosis. next please. الأهم من عندها والأكثر أهمية اللي احنا نسميه deep venous thrombosis. الديب فينس ثرومبوسيس الديب فينس ثرومبوسيس معناها thrombosis in the deep veins mainly in the calf، يعني الأوردة اللي موجودة في الأقدام مالتنا، اللي موجودة داخل العضلات العميقة اللي تصير قريبة عن العظام وقريبة على الشرايين. فهذه نسميها ديب فينس ثرومبوسيس. الديب فينس ثرومبوسيس موضوعها كلش أهم. ليش؟ لأنه الديب فينس ثرومبوسيس الكومبليكيشن مالتها أكبر. الكومبليكيشن مالتها أكبر. آه، كاتبين بالفيديوهات قصيرة، لأنه أنا محاضرتي حتى بالحقيقة هي بهالطريقة. هي محاضرتي بين ال 30 و 35 دقيقة، وما أعطي كل المعلومات. ممكن الطالب يعني أعطي بس الموست essential points، وأتمنى من الطالب أنه هو يرجع يقرأ بعض الأشياء بطريقة يعني مستقلة. نرجع للديب فينس ثرومبوسيس. الكومبليكيشن مالت ديب فينس ثرومبوسيس هي مهمة وهي خطرة. أول شيء اكو الديب فينس. أول شيء ممكن يصير عندنا، طبعا المريض ممكن يشفى اذا اعطيناه انتي كواجلانت، والثرومبوسيس will be dissolved and will cause restoration of blood flow. فاول احتمال ورا الدي فينس ثرومبوسيس ممكن المريض يشفى. هاي واحد. اثنين، الدي فينس ثرومبوسيس ممكن يصير في شيء نسميه propagation. propagation شنو يعني؟ يعني الثرومبوسيس تبدي تمشي داخل البلاد فيسلز. فبدل ما هي سادة مكان تقريبا 3 4 سنتيم، تبدي تسد مكان يطول 10 سنتيم او 12 سنتيم، راح تمشي within the vascular veins. فنسي نسميه venous thrombosis. هسه صار عندنا احتمالين: الاحتمال الاول resolution، الاحتمال الثاني propagation. الاحتمال الثالث نسميه detachment and emboli. شنو يعني؟ يعني جزء من هاي الثرومبوسيس بالفين. هسه احنا بالفين، جزء من هاي الثرومبوسيس will be detached from the original site and will migrate through blood flow. احنا وين؟ احنا بالفينز. تصعد الثرومباي الامبولاي عفوا، تصعد بالانفيرير فينا كافا وتوصل للرايت اتريوم، بعدين الرايت ventricle and will migrate where to the pulmonary arteries. pulmonary arteries راح تسد pulmonary arteries, so there will be abnormal oxygen transport. This will lead to dyspnea and hemoptysis. فالثرومبوembolism نسميها thromboembolism means there is a thrombi formation from deep veins and migrate to the pulmonary arteries. شنو الاحتمال الآخر اللي ممكن يصير بالديب فينس ثرومبوسيس؟ ممكن يصير عندنا فايبروسيس تنغلق تماما وتنسد تتحول إلى fibrous tissue, and later on the body will form few canals of blood flow within the thrombi, نسميها recanalization. This is the fate of deep venous thrombosis. So deep venous thrombosis more dangerous, more likely to have complication. آخر موضوع بالمحاضرة الأخيرة هو كان الامبوليزم. الامبوليزم means there is a migration of either thrombi، يعني اكو شيء ينتقل داخل الدم، اما thrombi او الامبوليزم. نرجع الامبوليزم ديتاش انترافاسكولار، اما سوليد اللي هي عاده تكون ثرومباي، او ليكويد اللي عاده يكون امينوتيك فلويد. امينوتيك هو السائل اللي يحيط بالجنين داخل داخل رحم المرأة يوترس، او غازياس يعني اير امبوليزم، يعني واحد ينجرح او يتعرض للحادث او يتعرض لانفجار، فالبلاد فيزل مالته اكسبوزد، فيدخل جزء من الاير يدخل within the vascular system. Next slide. صالح مشينا بالسلايدات شويه الكوزز. فالكوزز اوف امبوليزم، اما ثرومبوس قلنا مثل ديب فينس ثرومبوسس او اثيروما. مثل واحد انسان كبير بالعمر او يكون عنده اثيروما، وين تكون؟ عاده بالكوراتيد ارتريز اللي هي الشرايين العنقيه. فهذه الاثيروما اذا تتذكرون الصوره شفناها قبل شويه، قلنا سوينا تضيق بالشرايين، فجزء من عندها يصير بي ديتاتشمنت. وين يروح وين؟ للسنتر نيرفس سيستم، يروح للبرين، يسد لنا شرايين مال البرين and will cause brain infarction. We call it cerebrovascular accident. فراجمنت اوف تيومرز مرات جزء من التيومر، هذا مو كومن. الفات جلوبولز مهمه. شو احنا الامبولاي ممكن تكون فات. الفات وين ما كان موجود؟ وين مكانه؟ عاده الفات موجود بالبون مارو، بنخاع العظم. الفات عادة موجود في نخاع العظم، فيصير عندنا تروما من إنسان يتعرض إلى كسر بيأثر على بالضبط مثل ما فضلتوا انه ممكن اثناء العمليه ايضا يصير عندنا اير امبوليزم. لكن الفات امبوليزم وين يصير عندنا فراكتشر تو ذا لونج بونز. وين موجوده اللونج بونز؟ عاده بالثاي، عظام الفخذ من يصير بيها كسر راح يتحرر عندنا شنو؟ نخاع راح يتحرر عندنا شنو؟ يتحرر عندنا الفات الموجود داخل البون، ويدخل بالسيركوليشن. امينوتيك فلويد قلنا بحالات النسائيه يصير عندنا امينوتيك فلويد امبوليزم. Next slide
Wait,
please.
Doc, can I add something to this? Just because I know clinically this is going to come up in a lot of questions. If could you guys go back up one slide? I'm so sorry. So this is going to come up a lot in board questions is the fat globules because they always try to trick you. If the PE if basically they get an embolism right at like right at the time of injury, very close to it, you think fat globules. If they get it, let's say a week later, 2 weeks later, someone's wearing a cast on their leg or a splint on their leg because they broke their leg, then you have to think of a DVT that formed from compression of the vein, and then that caused an embolism. So that they always try to trick you on exams with fat globules, and then bubbles of air. Think anesthesia. Somebody is getting a surgery done, and suddenly they're like, "Whoa, wait, what's going on? Why are they decompensating?" It's because a lot of air got into the hoses. At like 200 cc's. So that comes up on test questions. Amniotic fluid. That's another one they always try to trick you. So if somebody develops sign of like pulmonary embolism, they get short of breath, they have trouble breathing, or they're getting a C-section and they decompensate right away, think amniotic fluid. But if let's say a woman develops signs of pulmonary embolism a week, 2 weeks later, sometimes even like 48 hours later, then think of again of a PE because they're in a hypercoagulable state and so then they got a thrombotic embolism, not an amniotic. So they always try to trick you. So the timing is important. Okay, sorry about that. Go ahead.
Thank you, Dr. Ammar.
Yeah, yeah,
It's nice to see you at last.
yeah. You too, brother.
So we mentioned the cause of emboli. Next slide. ال- Pulmonary embolism. Pulmonary is the most common form of embolism. This is the most common, and as Dr. Ammar said, most serious. Patient might have decompensation. That's we say a sort of shock state and life-threatening conditions. Usually, there is originating thrombus from deep venous thrombosis, as we mentioned earlier, in the veins, and this will migrate and blocking pulmonary arteries. So, where there is no blood flow, proper blood flow in the lungs. This lead to hypoxia, and patient will be dyspneic. Dyspneic means the patient will suffer from shortness of breath, chest pain, and hemoptysis. That is to say, blood in their sputum. So there is something in their lungs because of this deep venous thrombosis, and maybe this emboli it is large enough that may be fatal to the patient. Next slide. As you see in this illustration, this is a CT scan, CT scan cross section of the lung. As you see the white area, these are blood vessels and injected with dye material to become visible in CT scan. So you see this snake-like material, snake-like shadow, mainly with the red arrow. This huge emboli blocking the blood vessels. So it is a CT scan showing a huge emboli blocking the pulmonary veins. Next slide.
Sorry, brother. Can I add one more thing? Because in pathoma,
Yes.
this comes up too. So that one, if you can go back up, I mean, I think that's considered maybe a saddle, 'cause but it's only like a little bit on one side. But they always
Mm.
bring up saddle embolism, and that's in pathoma as well. So saddle is large, both sides. That's the way to remember it. And those people usually show up,
Oh,
unfortunately.
next
Yeah.
slide,
Oh,
we
okay.
have saddle.
Yeah, yeah. Okay.
So exactly as Dr. Ammar said, this is a saddle embolism, large emboli, as you see, blocking the bifurcation of pulmonary artery. So there's no blood really coming to the lungs, and this is usually fatal to the patient. This is the picture showing what is called, we call it autopsy. I don't know if you know it. Autopsy. This is pathological examination after death. So this is autopsy showing the cause of death due to huge emboli, sudden embolism, blocking the pulmonary arteries. Next slide. This is a diagram of causes of pulmonary embolism. When we have patients, usually may suffer from cardiac failure. Cardiac failure, this lead to slow blood flow. As we mentioned earlier in the thrombosis, low blood flow means there is more chance for RBC, white BC, and platelet to adhere to the endothelial cells and will initiate thrombosis. So, cardiac flow, cardiac failure, sorry, slow blood flow, this lead to thrombosis mainly in the venous side, mainly in deep veins, and this deep venous thrombosis will form an emboli, and emboli migrate through the pulmonary to the pulmonary circulation and will block, as you see in the picture, block this part of the pulmonary artery. So we have this is called a wedge infarction. Wedge, all the area supplied by that blood vessels will be will suffer from infarction because of ischemia. No blood coming to this area. So this is characteristic of wedge infarction and occlusion of supplying blood vessels. Next slide. We have also systemic emboli. Systemic emboli mainly in the right heart of in the left side of the circulation, mainly comes from the heart or aorta. So, as you know, left side of the heart will supply blood to the systemic circulation, So infarction will affect brain, for example, kidneys, spleen, while right side heart emboli will affect mainly the lungs. So a major cause for this systemic emboli is arterial fibrillation. Arterial fibrillation is a problem in the conductivity of the heart. The heart, the arteria will contract in irregular way, so we'll have abnormal blood flow in the arteria, and this will promote thrombus formation in the arteria. So this thrombi may be showering a detached piece of the thrombi. Systemic emboli could be we could be see it in the brain or kidney or in the spleen. Next slide. This picture illustrates fat emboli. So you see these are long bones and there is trauma, injury, and fat will escape from these long bones and enter the circulation and causing fat embolism, mainly affecting the lung, may lead to decompensation of lung and respiratory function. Next slide. This is a picture of amniotic fluid emboli. As we said in the earlier in this session, we said emboli could be solid, gaseous, or fluid. So this is example of fluid emboli. Amniotic fluid will migrate due to amniotic fluid. This is the fluid that surround the baby due to trauma or due to manipulation. So amniotic fluid will migrate to the systemic circulation and cause complication in the patient. Next. So what I need you to remember in this is the last lecture of the pathogenesis of thrombosis. We means varicose triad, the three things: varicose triad, the blood vessels, the coagulation factors, and the blood falls. All these three things will affect thrombosis. Second thing I want you to remember is the fate. Deep venous thrombosis, what is the fate? Either resolution or formation of emboli or propagation or fibrosis. The third thing I want you to remember is the emboli types, either thromboembolism or fat emboli or amniotic fluid emboli or gaseous emboli. Next. So this is a sort of exercise. And it's good time to read it. 60 years old woman with history of diabetes mellitus and has left-sided chest pain radiating to the arm for the past 5 hours. Serial measures of kinase elevated in 24 hours. PTT, partial thromboplastin time, and PTT are normal. Coronary angiography shows occlusion of the left anterior descending artery. Which is of the following mechanism is the most likely cause of thrombosis? So this case, we in dealing with the case, you should think in several dimensions. First, the age. This is an elderly woman. This is usually acquired condition. يعني unlikely to see inherited or congenital conditions present after 6 years. So this is the first part to analyze in a given case. Also, this patient have chest pain, diabetes, coronary angiography show thrombosis. So patient usually suffers from myocardial infarction or angina. Another information, there is increase in the kinase, and this is also indicator of myocardial ischemia. PT, PTT are normal, so there is no abnormality in the coagulation factors. Let's back to the question. Which is the following mechanism is most likely? So either we have antibody inhibitor to coagulation. This is not likely a coagulation disorders. Damage to the endothelium. Yes. Decreased antithrombin, not likely because mainly this is a congenital condition. Decreased tissue plasminogen activators, not likely. Mutation also, it is a genetic. Stasis of a blood flow mainly in the venous side. So we have arterial thrombosis. The most important factor in arterial thrombosis is damage to the
Damage to
endothelium.
the endothelium.
So very good answer we have here. So we are going good with that too. If you are not reading and answering, this is a good prognosis in the exam. Uh, but thanks for being inspiring students always يعني أعتذر إنه يمكن كان الموضوع كان يتقدم بطريقة أفضل. وأيضا إنه فرصة سعيدة إنه سمعت من عندكم، التقيت بكم. واحنا اسبوعين عندنا بعد على رح ناخذ مواضيع اضافيه. فانا يعني من خلال الشات بالجروب يعني مع البنات ومع الولد، اذا عندكم مقترحات انه نستفاد من الوقت اكثر، واثناء ما تقرؤون المحاضرات اذا عندكم اسئله فاني حاضر باي وقت. يعني أنا اخلص دوامي قبل ساعه من هسه، في اي وقت من وراء الثنتين بتوقيتكم تسالون، انا حاضر الاجابه. وهسه اذا احد عنده سؤال او شيء او تعليق، فاحنا نسمع قبل ما ينتهي الوقت.
Doug, are you just asking for questions? That
Yes,
okay.
sorry, sorry,
Okay, okay.
sorry, Dr. Ammar, sorry,
No, 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 no.
sorry,
I'm sorry.
Dr. We finished. We are waiting for questions. It seems there are
Yeah.
limited numbers participating because of the circumstances. I think
No, that's fine. I mean, we
with
can,
the help of Saleh, things get better in the presentation.
yeah, and I mean, we can always, if the kids don't have any questions, we can just go over. I always like to just go over the diseases. If they don't have any questions, we can just run some clinical scenarios over the diseases because that's always what comes up in exams. But if you guys have questions, please send them right now.
They want what do we a
Case
cases
questions.
for
Yeah.
pre-exam. They ask for a cases in a pre-exam for as exercise.
Yeah, bro. I think the questions that you emailed me, I'm gonna the ones that you wanted to send out, um, I'll send it to the students today. Um,
تمام.
and then okay, I mean if with your permission, Doc, I mean we can go over. I wrote down some clinical scenarios. We can just quickly go over them. Does
Yes,
anybody have
yes,
anything else? Okay.
they have no comment. Proceed, Dr. Ammar.
Okay. So, guys, so go
The
ahead.
screen.
Yeah, Saleh, go ahead.
Should I stop the screen sharing?
Yeah,
Yes.
you can stop the screen sharing. So I wanted to go over just in the because a lot of the most confusing things in this chapter are going to be the clinical scenarios because a lot of diseases they sound like when you read the description you're like this sounds like the same disease but maybe with one or two differentiations. So let's start with primary hemostasis. Um, ITP, I think I mentioned earlier, you know, it's this is going to be somebody that doesn't look very sick and you're gonna let's say a kid comes in has a viral syndrome for some reason you got blood work and you notice the platelets are a little low and you're wondering why that is even though the kid clinically looks great. um, that's you know you think ITP and ITP remember the it's always going to be a normal PTT because the secondary hemostasis is not affected when it comes to ITP, so immune thrombocytopenic purpura. um, and if they need it, they can get IVIG, which is intravenous immunoglobulin, which you know, and theoretically um, helps bring the counts back up. It also says in pathoma that you know splenectomy eliminates the primary source of antibody in the site of platelet destruction. I've never clinically seen somebody need splenectomy from ITP. I don't know, doctor, if you have either, but that's you know extreme case scenario. Okay. Um, Microangiopathic hemolytic anemia. This is a classic exam question that comes up is um, uh, a kid was, you know, eating a hamburger and the hamburger wasn't cooked properly. Well, okay, now they have E. coli. Now you have to think, okay, what happened? Well, the pathogenic processes, they didn't eat the hamburger that was cooked correctly. The hamburger had E. coli in there. Okay, the E. coli was O157 colon H7. Again, why they always ask that, I don't know, but it always comes up. E. coli O157 colon H7. So that's what the kids accidentally ate. And unfortunately, now they got microangiopathic hemolytic anemia via a disease called hemolytic uremic syndrome. So HUS and TTP both cause microangiopathic hemolytic anemia. Okay, so and in this situation, again, it's a disease of primary hemostasis. So you're going to have um, thrombocytopenia with increased bleeding time, and your PT/PTT is going to still be normal. But the differentiation between this and ITP is that you're going to have schistocytes. Schistocytes, basically, think of them as little emboli that form inside your blood, and they're just shooting missiles into your bloodstream. So all the platelets get together in little clumps. They shoot down like little missiles, and they hit everything in their path. And one of the things they hit is red blood cells, and the red blood cells explode and you get little fragments called schistocytes. So the only way clinically I can tell the difference between ITP and HUS, one of the biggest ways is if the pathologist comes back to me with the blood slide and it says presence of schistocytes. And so that's kind of a big giveaway. And all these things are going to have megakaryocytes in the bone marrow, increased megakaryocytes. Again, clinically, you're not going to really see that really often, but because they won't report it. But it's basically that means more platelets are being produced. So the platelet production is not affected; it's the platelet consumption. So anytime you see somebody with thrombocytopenia, which means low platelets, think either the platelets are being used very fast or they're just not being produced, right? So just if you can remember those two mechanisms as a medical student, that's I'm very impressed by that. Okay. Um, and then qualitative platelet disorders, this means they have platelets, but they're just not working, right? So you'll check their platelet count, and the platelet count will be normal, but a lot of times they'll have increased bleeding time, and you're like, this doesn't make any sense. Well, maybe the platelets aren't working. So, for example, somebody accidentally takes an aspirin before surgery, right? So if you think of a classic pathway, patient presents, they took an aspirin before surgery, they're having, prolonged bleeding time. You're like, what's going on? Oops, they took a medication, right? And then a lot of times you'll see this with alcoholics, people who drink a lot of alcohol. They're also going to have, they're going to have normal platelets, but they're going to not be functional. Uremia, so people who have, kidney failure, and you check their BUN levels in their blood, which we're going to get to, but they're going to have, in the kidney section, but they're going to also have dysfunctional platelets. So the platelets are not there, the platelets are being consumed, or the platelets themselves are dysfunctional. Those are three mechanisms by which you have primary hemostasis disorders. Now, quickly moving on to secondary hemostasis disorders, hemophilia A and B. I remember these as the classically they're taught as the ones that a lot of um, nobility in Europe, that would get. So all the kings and the queens, they would only marry members of their own family, and so classically a lot of those people would get these diseases, right? Because they're X-linked, especially hemophilia A in particular. So in this situation, you have to just memorize it. Hemophilia A is factor 8, and hemophilia B is factor 9. And the treatment is you just give them those factors that are missing. So they cannot. So these people again have a problem with the secondary hemostasis. So their coagulation cascade is messed up. And I would encourage, if any of you cannot remember the coagulation cascade, to go back and just look at one of the diagrams to go over it. Von Willebrand's disease. I'm gonna skip that. But vitamin K deficiency. So remember, anytime they're gonna say a newborn baby, has any kind of presents with any kind of signs or symptoms of a secondary hemostasis disorder. So, you have to think, okay, did they get a vitamin K shot when they were born? Babies are not born with sufficient vitamin K. That's why as soon as they're born, we give them a vitamin K shot. And unfortunately, a lot of parents who are, want natural, whatever we call it, they'll refuse it. But that's why it's very important. And I know Dr. Muhammad, he brought up liver failure because obviously then you're not making the coagulation cascade, the components for the coagulation cascade. And then large volume transfusion. That's also something that's very clinically important. Unfortunately, in a lot of the parts of the world now, we're seeing a lot of trauma. So people come in, they're like, okay, they're losing blood, they're losing blood. You give them blood products, but you forget to give them coagulation products, right? So if let's say I transfuse a patient with 7, 8, 9 units of blood, I don't give them any coagulation factors. So, FPP, they call FPP, fresh frozen, or FFP, sorry, fresh frozen plasma. If I don't give them that with the blood products, if I give too much blood without it, then I'm gonna accidentally make them bleed too much. Another way that's not mentioned in your book, but I think is very important, somebody comes in with trauma and you give them tons of normal saline. Like, you notice their blood pressure is dropping because they lost a lot of blood, but instead of giving blood, you give a lot of fluid, which happens because sometimes we don't have it fast enough. Well, then you dilute the coagulation factors, and then they start to bleed as well. So those are what we call iatrogenic causes that we created as doctors to the patients. Um, Other disorders of hemostasis, heparin-induced thrombocytopenia, also known as HIT. HIT comes up. You're gonna learn more about that in your pharmacology class if you haven't gotten to it. But HIT comes up anytime someone is on heparin. You have to be cognizant of this thing. And then DIC, disseminated intravascular coagulation. We spoke on this earlier, but again, this looks like sometimes people, this looks like ITP, TTP, DIC. Those three are always very similar. So ITP, DIC, and TTP, just always kind of remember in your mind how to differentiate them. DIC will be high PTT and PT and PTT as well as low platelets. So it's going to have primary and secondary components. So, and then also it's going to have elevated D dimer um, and decreased fibrinogen. And that's going to be also indicative of a secondary hemostasis disorder. So that comes up quite a bit. Um, Thrombosis, I think, the doctor talked about very well. I don't think we need to go too much into that. Um, but the biggest thing to remember is somebody comes in with a DVT or any kind of clot for the first time, the protein C, S, von Willebrand, these are all the things that you're going to test for when you get to your clinicals to see what's causing it. And lastly, on embolism, we spoke a lot about that, but pulmonary embolism, classically, though, sometimes a lot of clinical scenarios that they'll present is, for pulmonary embolism will be, young person who goes to sleep and doesn't wake up, right? A very common cause is they had a PE, and it's because they had some underlying coagulability disorder. And obviously, think about it after, you think about it after trauma, you think about it after pregnancy. So don't be fooled into thinking that it's only a fat embolism or only a amniotic fluid embolism. But that's all I had for clinical scenarios. I know that's a lot, but we're gonna send out questions, and inshallah that you guys can go through those and improve on them. Does anybody have any questions in English, please?
They they
If
they have a question about the exam format. They want 40 MCQ instead of 20.
I don't
Is
know
my-
what you mean by that. How many
uh,
questions are on the exam?
yes, yes.
I will find out from Dr. Shakura, guys, because I know for the first exam, this was supposed to be chapters 1 through 4, but given, ongoing hardships, we're just going to do chapters 3 and 4. Um, so I will let you know I'll get back to you. That's a good question. I will get back to you on how many questions there's going to be, whether it's just going to be the size of the quiz or it's going to be a bit longer. Um, but yeah, but I mean, but please don't, I will add this, please don't forget chapters 1 and 2 because they are going to be on your final exam. And that's kind of the agreement we have since, we're not doing a cumulative midterm exam. Is there any other questions, Doc? Can you translate them for me? Is it, yes, um,
No, there is no comment, other comment.
okay.
They,
Um, okay. All right. Does anybody last minute, anybody have any questions? Anything? And I'm going to record this and put it up too. So, okay. All right. All right, doctor. Well, thank you so much for your time. And
thank
inshallah.
you, Dr. Ammar. Very
Yeah.
appreciate your effort.
No, I appreciate your effort too. You're in Baghdad, correct? So thank you for teaching from out there, and I appreciate everyone's time. And like I said, if you guys have any questions, please, message us in the WhatsApp groups. Inshallah, we'll be watching them and answering any questions. But for this exam, all I can say is, focus focus on the clinical scenarios, especially for chapter 4. I think that's the most high yield stuff as well. Okay.
Thank
Okay,
you all
thank you,
for
Dr.
coming.
Ammar.
All right. Thank you, brother. All right. Thank you, everyone. Assalamu alaikum.
Assalamu alaikum. Thank you, Dr.
Alaikum
Bassam.
salam.